Next, we have Dr. Partha BISWAS, who needs no introduction. He's the man behind this entire scientific show, a wonderful scientific extravaganza that he has put up. And Partha is going to be speaking to us about managing posterior capsular rent. He comes with a very wide experience both in cataract surgery and refractive surgery, and it would be good to know his nuances of how he deals with this problem.
Thank you very much, sir, for that very kind introduction. And to tell you the truth, as a member scientific committee, I learned a huge amount from not only Dr. D. Ramamurthy and Dr. Lalit Verma, but all the preceding chairman scientific committees. And I hope you're having a good time today. And any problem, the one point contact for you is me. So any problem anywhere, please let us know. The next thing, of course, I don't know why Ramamurthy sir gave me this posterior capsular rent topic. Maybe my experience was highest in this, I don't know. So we'll come to this topic and assess it in that way, in a very practical situation. If a posterior capsular rhexis is possible in a patient who has a PCR, a PC rupture, then things are different. If it is not possible, then things are different. Now let us look into the situation where it is impossible to have a PCC. So this is a situation in which there is a large chunk of nucleus you can see, and we have detected that there is a PCR there, a posterior capsular rupture has occurred. So what we are doing is to compartmentalize this area into two by high molecular viscoelastic. Vitreous has not come in, so the nucleus is set apart, and we can still do a good phacoemulsification, keeping in mind that if little bit of vitreous is there in the anterior chamber, that has to be ascertained first. And that can be done with placing the tricot in the anterior chamber. This was not needed in this case. So more or less we have not had, and therefore we are going ahead and doing also the cortical cleanup in this case. So once the cortical cleanup is done, things are much easier. But we need to know that the microscopic view that our best microscopes offer us may not be the proper guide always for a vitreous that is in the anterior chamber. So we place in the lens, but what is the most important thing here is not only placing in the lens, and we place it in the sulcus here. It's a 3-piece lens, safest if you have any issues, and that means you have to have a 3-piece backup for every case of yours. I'm doing that sweeping part, which is actually not the best thing to be done or to be practiced all the time. What is important for the practice is this: you have to put in triamcinolone in the anterior chamber and see that there is any vitreous at all or not. If there is none, then the job is done. So let's go to the next one. The next video is a video that shows you that everything was going on very, very well. And it was at this very last time that there was a PC rupture. Now, a PC rupture occurs, as we know, the commonest occurrence time is when the IA is going on. And now we have a small PCR that has occurred, and it's very important to convert it into a nice PCC. So it cannot be always done. What is important is to place high molecular weight viscoelastic in the anterior chamber, not too much, not too less, just enough to get that concavity. And then with the microrhexis forceps, all that you have to do is a nice small capsular rhexis can be carved out, and then this bag is stable. You can put a 3-piece, you can put a single piece, and the job is done. Of course, a bulky 3-piece, like a single piece like this in the Rayner style, can also stand a ruptured bag because it's been converted nicely into a PCC. Now let's look at the next experience that we have. It's a large PCR, and with this large PCR that is there, and there's quite a grade 3, grade 4, grade 3 nucleus there in the anterior chamber, we take it off and gradually this amount of PCR that there is, it's not possible to convert it into a PCC here. So we are able to take off the most of the part of the nucleus, and as we take off the nucleus part, then what we have is we need to put in the viscoelastic while the phaco needle is in place, and that's an amount so that we are able to remove also the cortical matter. So in most of these cases, the point where vitreous comes into the anterior chamber, that is the point where you have to put triamcinolone, do a vitrectomy, and then go to the next step, which is actually mandatory. Now, placing a three-piece lens into this, again into the sulcus, and capturing it, because you have a nice capsular rhexis, and the capturing will ensure a good centration. We'll go over to the next video, and here is a video that is actually controversial. Now, a trifocal IOL in a PCR, should you or should you not? This patient had a trifocal IOL in the first eye, and therefore with a PCR, and we could put it in the bag. So we placed it in the bag, and this trifocal IOL in the bag does give the possibility where you can do it when you can put a trifocal IOL even with a PCR. However, if you cannot put it in the bag, it's best to abandon the trifocal and then place sulcus, a three-piece lens in the sulcus with the amount of counseling that you have to do to the patient. But it's important to remember that these lenses are for long term. You just put it in and you say that everything has gone on well, is not the job done, because these patients will have problems of if you place a single piece lens in the sulcus, the problems that we know of, uveitis and rotation and difficulty, all those things will occur post-operatively. It's best not to be done. So here we'll go over to this next case. Now I'll just go into the last two small clips of videos. There is no PCC. We cannot do a PCC in the next two cases, but can we still put a IOL in the bag? So these are two important cases. They have to be taken as it comes. If you feel that you have the expertise, if you feel that the situation is good, if you feel that there is no vitreous into the anterior chamber. I have 1 minute, I think, no, sir? Okay. So now this is a posterior capsular rupture. You can see it's a transverse rupture of a posterior polar cataract. So what we are doing is we are landing this single piece lens in front of the iris. That's the technique that has to be followed. So the single piece lens goes in front of the iris, and then you have to hook and pivot it with your manipulator and place it directly under good supervision and under good control inside the ruptured posterior capsule, but you have the anterior capsule intact, and you have that part of the posterior capsule which works like a hammock. And also in the trailing haptic, you have to do the same. So it's curving the arm of the haptic, that is important, and it has to be landed in the bag. There should not be vitreous into the anterior chamber. Then only you should go ahead and try this technique. This technique is good, but in very limited cases, and if you think you have the expertise to do it, please go ahead and do it. This is the last of my videos, and this is a little more difficult. It was a longitudinal and eccentric rip that we had. Just 1 minute. So this is a longitudinal rip that we had. The other one was a transverse rip. Here we are placing the high molecular weight viscoelastic in the bag, and then getting across to take off the cortical matter. And once the cortical matter is taken off, you can see that it's again very important that replacing and refurbishing the anterior chamber with more and more viscoelastic as and what is required. And you can see that the longitudinal tear is there. I'm opening up with high molecular weight viscoelastic the space between the anterior capsule and the ruptured posterior capsule. That is again another technique that one has to follow. And again, landing this intraocular lens, single piece intraocular lens in front of the iris. Once it is in position, then I turn it around and then place it. The pupil has to be very widely dilated. We have to see that it is going inside the bag and nowhere else, because if it goes and sinks into the vitreous cavity, it's a mess, and then you have to take it out and remove it, do a vitrectomy, and then put a 3-piece lens. But if one can get it through like this, like what we are showing, you will have a stable bag even though it is ruptured and you have not created a PCC. So these are a few situations that I wanted to share with you. And of course, triamcinolone assisted vitrectomy, if it is required, is very, very important. Thank you very much for your patient hearing.
Excellent videos, Partha. I mean, almost covered all aspects. Dr. Chetial, I want your inputs on this. All the cases which were so efficiently managed, Partha did the anterior vitrectomy through the limbal route only. There was no pars plana incisions. Nowadays, there's a lot of talk about this. I personally also do what Partha does. I have done through pars plana, but more often I find that I've been doing it for 20, 25 years, and I find that it works quite efficiently for me to do through the limbal route itself. And of course, as he showed, checking with the triamcinolone acetate. What is your take on this? Are you, any of these complications, are you doing only through the pars plana? You also tend to go through the limbal route?
I think what Dr. Partha showed, followed by 99% of our surgeons. I think that is the way we have been handling these PCR happening on the table most of the time. I also do the same thing. I do anterior route only most cases because it is important to detect PCR as early as possible. And your management can be much easier if you can pick up early. It is only when things become out of the control, then you are in a difficult situation. Doing a pars plana vitrectomy at that stage can be really challenging for an anterior segment surgeon. The patient is most of the time under topical anesthesia, and chamber is loose, it's not tight, and making the port is also very difficult in these cases. In that process, you might create more damage than doing a simple anterior vitrectomy, because you require very little anterior vitrectomy in these cases. And the use of triamcinolone, which Dr. Partha showed, really gives a good clue that you have done a good vitrectomy in these cases. We don't have to go in a pars plana that will disrupt so many things. Untrained person. I've seen people creating complication because of that only, and I've seen expulsive happening in that case because the amount of force by the person doing in the open chamber, and the entire thing is coming out, the vitreous whole thing coming out, and even a retina is coming out in one case. So unless you are expert in that, don't try that. Try a simple anterior vitrectomy through anterior route, and you can manage very nicely. You have 2 side posts, do from 2 side posts, change your hands, and you can effectively do vitrectomy there.
Good. You have any comments, Suresh?
Just had a quick question, sir. For the triamcinolone acetate, when we are putting it, do you dilute it or do not dilute it?
Yes, I usually dilute it. And the diluted one, in the earlier days, I would not dilute it. And it does not actually create the problems that we actually read in the papers and the textbooks. So the IOP going up and things like that. But what also, as of now, I'm diluting all of them. But it definitely gives a very good post-operative result. The cornea is very pristine nearly the next day. So despite having trouble, the patient is seeing quite well.
No, the reason I ask is that the retina surgeons say that the vitreous stains better when we don't dilute it. When we dilute it, it may not stain very well. And I also noticed in one of your cases where you have already implanted the IOL and then you're putting the transplant to look for any residual strands.
Yes.
In those cases, it's very unlikely that the transplant will seep into the vitreous because the IOL is already there. So would you recommend just not diluting in those cases to visualize better?
Basically, it is a good wash of the triamcinolone also is important, and the triamcinolone should not go into the vitreous cavity, which is important.
Right.
Thank you.
Excellent. I think you brought up two very important points. There's so much of talk and by excellent surgeons with good videos saying that the pars plana vitrectomy is the way to go. As Dr. Titial said and Dr. Partha showed, if you are comfortable going through the anterior route, using triamcinolone acetate and doing an adequate vitrectomy quite often takes care of the case. And I'm sure that's what most of us are doing. Another very important point was that whenever the nucleus goes in, he did not even show any video of that. Once the nucleus drops, once it goes beyond the anterior chamber, then I think we are not going to be discussing this because we are essentially anterior segment surgeons sitting here. Once it goes in there, then you just do an adequate wound toilet, anterior vitrectomy, remove whatever cortex is easily possible, then call up a vitreoretinal surgeon to handle the case. If you are in an institutional setup, it can be done on the same day, or even if the patient goes back in a pseudophakic or an aphakic state, 2-3 days later, it can be taken care of quite adequately. Thank you so much, Partha.
Just one point I like to highlight, because all these cases where you have PCR and you have done vitrectomy, the post-op management is very, very critical in these cases. You must do a peripheral screening within the first few days and keep seeing these patients every month and make sure if the patient understand what is floater and flashes, because these patients can have these symptoms anytime in the future. Immediately they should report so that you can manage those difficult cases. They may have a small tear, small hole, traction can be managed, and OCT is must in these cases in the regular follow-ups.
Thank you.